the lateral spinothalamic tract, and then you have the anterior spinocerebellar and the posterior spinocerebellar tract. Apart from the posterior column tracts, facialis, gracilis and the cuneus, this carries the position joint sense and this carries the touch. And then the descending tracts will be, the main thing will be the lateral corticospinal tract, rubrospinal tract, reticulospinal tract, and then you have the anterior corticospinal tract, tectospinal node. Predominantly will be the corticospinal tract, and this is the gray matter, and here you have the anterior horns and the posterior horn cells will be present. So in the lamination, if you take the posterior column, the lamination is from the sacral fibers and outside is the cervical fibers. As the fibers from the leg come up, it goes and subsequent fibers join, and so you have a lamination which is sacral is interior and the cervical is the outermost part. Whereas in the corticospinal tract, it is just the reverse. The cervical is inside and the lumbar is the outermost, and similar to that is the spinothalamic tract also. The spinal nerves connect to specific areas of the body through spaces in the vertebrae. They have the two roots, the motor root and the sensory root. The motor root carries signals from the spinal cord to different parts of the body. Suppose I have to move my hand, then I have to have a motor root which will come. Move my thumb, then the root will have to come from the cervical vertebra to from the cervical spinal cord to my thumb to move it. Sensory root carries information from the like touch, pain, temperature from the body to the spinal cord. And then you have also other sensory root with release messages to different areas of the skin. This is known as the dermatomes. We will see shortly how the dermatomes are there. So coming to the grey matter organization, as I said earlier, you have the anterior horns, motor neurons here, and you have the posterior horns, the interneurons are also present, the dorsal root, sensory root, dorsal root ganglion is there, and then which carries a somatic sensory and the visceral sensory. Apart from the anterior root carries the visceral motor and the somatic motor. This is the anterior root which is a motor, and this is the dorsal root which is the sensory root. This is from the grey matter, and you have the intermediate interneurons also and the intermediate horn cells in certain parts of the cord. The functions of the spinal cord will be the motor, sensory functions, and apart from it also subserves our reflexes, the bladder bowel control and the sexual functions. Localization specific to myelopathy will depend on where it is affected in the spinal cord, whether it is cervical, thoracic or lumbar. Cervical cord can produce, if it's high cervical cord, it can produce a quadriparesis or plegia, thoracic cord can produce paraparesis, and lumbar cord can produce monoparesis or even paraparesis. Precise localization of the actual myopathy will determine the specific signs and symptoms that will occur. Though we have 33 vertebrae and 25 discs, all of them are susceptible to damage, and the range can be from mild to severe. So whenever we think of spinal cord disorder, we have to find out what is the motor change, what is the sensory change, and whether there is bladder, bowel, other autonomic involvement is there, and then with the reflexes. So that is how we localize. The localization we will tell the motor level, the sensory level, the reflex level, and autonomic level it is present. So it will convey to us the anterior to posterior extent, the vertical extent as well as the side to side extent. So common symptoms will be weakness or paralysis, changes in the reflexes, the acute phase spinal cord disorder may be lost, and in chronic myelopathies it may become exaggerated. Loss of urinary or bowel control can be there, uncontrolled spasms can be there like flexor spasms, back pain can be there, loss of sensation. If it's a particular dermatome, it can indicate spinal cord involvement at that level, and it may help us in localization. So you can see it can be a monoplegia, it can be a hemiplegia, spinal hemiplegia, it can be a paraplegia, both the lower limbs are affected, or quadriplegia when all the four limbs are affected. As I said, these are important dermatomal landmarks for the sensory roots. Posterior half of the skull pack, C2. High collar area, this is the turtleneck shirt, and then the low collar area will be the C4. Lateral part of the arm will be C5, radial side will be till the thumb will be C6. And these three digits will be C7, this is the C8, and the nipple region will be T4, inframammary fold is T5, Zephyr process will be C6-7, umbilicus we all know is T10, and the pubic bone will be T12, and L1 is the inguinal ligament and L4 is the kneecap. Roughly these are the areas, let us see. So as you can see, this C3, C4, C5, C6, and then C7 is all the three fingers, C8, T1, T2. Okay, anterior as well as posterior. Here you can see lower part of the abdomen, umbilicus is T10, then below T11 and T12 is the inguinal ligament, and L1 is just below the inguinal ligament. L2 is like this. If you keep your hand like this, then you will find that 5 fingers, 1, 2, 3, 4, 5. It will be like that, where the L5 will come up to the foot, S1 will be part of the foot and the plantar aspect. And as you go higher, you find that S1, S2, S3, S4, S5 are there. And the anteriorly, S2, S3 will innervate the genitalia also.